Assalamu alaikum. I'm Professor Dr. Hayder Mubarak. This is a presentation to embryology of the head and neck. In embryology of the head and neck, we will consider every structure that is derived from the mesodermal tissue blocks lying on the sides of the neck, or we can say these are mesodermal tissue blocks lying on the sides of the pharynx and on the side of the neck. These mesodermal tissue blocks are called pharyngeal arches or called branchial arches, and even sometimes they are called Gill's arches. The mesodermal pharyngeal arches, the tissue blocks, are separated from outside by grooves of ectoderm that are called pharyngeal cleft or branchial cleft, and also these mesodermal arches are separated from inside from the pharynx by endodermal grooves of the pharynx that are called pharyngeal pouches or called branchial pouches. So we will start the description about the pharyngeal arches, the mesoderm tissue blocks on the side of the neck. Derivatives of the mesoderm from the first pharyngeal arch includes bones and muscles. Bones derived from the mesoderm of the first pharyngeal arch or branchial arch are the zygomatic bone of the skull and part of the temporal bone of the skull. And also, bones derived from the first arch include the incus bone and malleus bones, which are bones of the ossicles in the middle ear. The mandible is also derived from the first arch, but it is not from the formed by the first arch by cartilaginous ossification, just like the other bones that I had just enumerated. The mandible is initially formed as a cartilage model of mandible. This cartilage model is called Meckel's cartilage. But this Meckel's cartilage will not ossify by chondral ossification, but mesenchyme around the Meckel's cartilage will ossify by membranous ossification. So the mandible is also derived from the first arch, but it is different from other bones of the first arch as it is formed of membranous ossifications of the mesenchyme around the Meckel's cartilage, which is the cartilage of the mandible. These are the bones from the first arch. Muscles of the first arch, or muscles derived from the mesoderm of the first arch, include number one, muscle of mastication, which are temporalis, masseter muscle, medial and lateral cricoid muscles. These muscles of mastication moves the mandible during chewing. In addition, the mesoderm of the first arch gives a muscle in the middle ear, which is called tensor tympani muscle, and gives muscle moving the soft palate, the uvula, which is called tensile palati muscle. Regarding the second arch also form bones and muscles. Bones derived from the mesoderm of the second pharyngeal arch are the styloid process, which is a bone in the base of the skull below the ear, the auditory meatus, the ear canal, styloid process, and also the upper part of the lesser horn of hyoid and the upper part of the body of hyoid and the right and left lesser horn of hyoids are from the second arch, the mesodermal arch. And that's why the second arch is sometimes called hyoid arch, because it forms the lesser horns of hyoid and the upper part of body of hyoid. Also, the second arch forms the stapes, which is the third bone of the ossicles. We have said that the malleus, incus are bones of the middle ear ossicles formed from the mesoderm of the first pharyngeal arch, and now we can see that the stapes is in the third ossicle bone in the middle ear. It is derived from the mesoderm of the second arch. Muscles derived from the second arch are muscles of facial expression that are seen in the superficial fascia of the face, and their contraction produce facial expression. Regarding the third arch also forms bones and muscles, just like the first arch and second arch. The mesoderm of the third arch forms the following bone. It forms the greater horns of hyoid bone, and the lower part of the hyoid bone, while the muscles derived from the third arch include muscles that are supplied by the non-cranial nerve, which is the glossopharyngeal nerve. One of these muscles is a muscle called the stylopharyngeus. It originates from the styloid process inserted into the pharynx, and so it is a muscle of the pharynx called the stylopharyngeus, supplied by the non-cranial nerve, which is a glossopharyngeal nerve, and considered as an example of muscles derived from the mesoderm of the third arch. After the third arch, we must consider the fourth and sixth arch, because we don't have fifth arch. The fifth arch is degenerated in a human. The fourth and sixth arch are considered in terms of their derivatives collectively, because these two arches gives cartilage and muscles, not like the other three arches we had discussed them before, forming bone and muscles. This arch forms cartilage and muscles. Cartilage derived from the fourth and sixth arch are cartilage of the larynx. They are thyroid cartilage, cricoid cartilage, arytenoid cartilage, corniculate, and cuneiform cartilage. These are cartilages forming the skeleton of the larynx. Muscles of the fourth and sixth arch must be considered separately. Muscles from the fourth arch include cricothyroid muscle, which is a muscle of the larynx, levator palati muscle, which is muscle of the palate, of the uvula, of the soft palate, levator palati, and constrictor muscles of the pharynx. We have superior constrictor, middle and inferior constrictor. All of these constrictors are muscles derived from the mesoderm of the fourth arch, while muscles derived from the mesoderm of the sixth arch include small muscles connecting the cartilages of the larynx that we had enumerated before a while. We said that the larynx is formed of cricoid, thyroid, arytenoid, corniculate, cuneiform cartilages. All these small cartilages are connected by small muscles called intrinsic muscles of the larynx that are derived from the mesoderm of the sixth pharyngeal arch. This is all about the arches. The structures derived from the pharyngeal arches are supplied by the nerve specific for that arch. So all the structure derived from the first pharyngeal arch, from the mesoderm or the first pharyngeal arch, are supplied by the trigeminal nerve, which is the fifth cranial nerve. This trigeminal nerve gives branches which are maxillary and mandibular branches of the trigeminal, which is the fifth cranial. And these maxillary and mandibular branches supply all structures derived from the first pharyngeal arch, while structures derived from the second pharyngeal arch are supplied by the facial nerve, which is the seventh cranial nerve. Structures derived from the third pharyngeal arch are supplied by the glossopharyngeal nerve, which is the ninth cranial nerve. Structures derived from the fourth pharyngeal arch are supplied by the vagus nerve, which is the 10th cranial nerve, specifically the superior laryngeal branch of the vagus. And the structures derived from the 6th pharyngeal arch are supplied by the recurrent laryngeal branch of vagus nerve, which is the 10th cranial nerve. Of course, we don't have 5th arch because the 5th arch, as we said, degenerates in human. Next, we will talk about derivatives of the pharyngeal pouches. And we said the pharyngeal pouches are grooves from endoderm of the pharynx separating the mesoderm of the pharyngeal arches from inside. These grooves are 5 pouches. All of them are formed by the endoderm of the pharynx. So, to enumerate structures derived from the pharyngeal pouches, we will start with the first pouch. The first pouch forms the Eustachian auditory tube and the middle ear cavity. You know, the Eustachian tube is connected with the pharynx, or it connects the middle ear with the pharynx. So the Eustachian tube and the middle ear cavity, which is called tympanic cavity, are derived from the first pharyngeal pouch. Even the inner layer of the eardrum, which is the tympanic membrane, is derived from the endoderm of the first pouch. Actually, the auditory tube and the tympanic membrane initially are called tubotympanic recess, but later on they will form Eustachian auditory tube and middle ear cavity, in addition to the inner lining epithelium of the eardrum, the tympanic membrane. Derivatives of the second pharyngeal pouch is the palatine tonsil. Derivatives of the third pharyngeal pouch is the inferior parathyroid gland and thymus gland, which is the lymphoid tissue behind the manubarium of the sternum. So the third pharyngeal pouch form inferior parathyroid gland and thymus gland. The structures derived from the fourth pharyngeal pouch are the superior parathyroid gland. The fifth pharyngeal pouch, which is sometimes regarded as part of the fourth, form an ultimobranchial body that gives rise to C-shaped C cells of thyroid gland, which are parafollicular cells secreting calcitonin hormone of the thyroid gland. This is all about the pharyngeal pouches and their derivatives. Finally, we have to talk about pharyngeal cleft, and we say that the mesodermal pharyngeal arches are separated from outside by grooves lined by ectoderm, which are called pharyngeal cleft. Actually, these clefts are 4 clefts, and they are formed in the same period of the pouches at the 5th week of the embryonic life. Derivatives from the pharyngeal cleft include derivatives only from the first cleft. The first pharyngeal cleft or branchial cleft form the ear canal, which is the external auditory meatus. And also the first cleft form the outer layer of the eardrum, which is the tympanic membrane. You can see that the eardrum, the tympanic membrane, is formed by the inner layer of the eardrum is from the endoderm of the first pouch. The outer layer of the eardrum is by ectoderm of the first cleft, and in between this endoderm and this ectoderm is a piece or a thin piece of mesoderm. So the clefts, only the first cleft is the cleft that gives the ear canal. The second cleft, third cleft, and fourth cleft will be closed, forming cervical sinus. And the closure of the second cleft, third cleft, and fourth cleft occurs by overgrowth of the second arch. The mesoderm of the second pharyngeal arch grow and close the second cleft, third cleft, and fourth cleft. This closure forms the cervical sinus that later on degenerates. If this sinus will not degenerate, it will form a lateral cervical cyst that may open to outside, produce a branchial fistula. This figure also shows a demonstration for structures of the pouches derived from the pouches. So this is all about the arches of mesoderm, the pharyngeal arches, the pouches, which are endodermal pouches from the pharynx separating the arches, and the cleft, which are ectodermal grooves separating the arches. Now we have to talk about embryology of the tongue, because the tongue is also derived from the mesoderm of the pharyngeal arches. Actually, the anterior 2/3 of the tongue, which is called body of the tongue, is derived from the mesoderm of the first pharyngeal arch. The mesoderm of the first pharyngeal arch forms bilateral lateral lingual swellings and one median lingual swellings, which is called the tuberculum umpar. These 3 swellings form the anterior 2/3 of the tongue, but mostly from the lateral lingual swelling, which is called body of the tongue, the anterior 2/3. While the posterior 1/3 of the tongue is derived from the second pharyngeal arch, third pharyngeal arch, and fourth pharyngeal arch. These 3 arches, the second, third, and fourth, form a median hypobranchial eminence, which is called also copula, that form the posterior 1/3 of the tongue. But you can see in the figure that the yellow color is the most prominent, forming the posterior 1/3 of the tongue. Of course, the posterior 1/3 of the tongue is called root. So you can imagine that the third arch, which is drawn here in yellow, overgrow the copula derived from the second and fourth arch. So although the copula is from the second, third, and fourth, but the third overgrows the second and fourth and dominate in formation of the posterior one-third, which is the root of the tongue. Behind the root, there is a small swelling, which is called epiglottic swelling, is derived from the fourth pharyngeal arch, and it forms the distal or the posterior end of the tongue, the epiglottic swelling. In consideration to these embryological swellings forming the tongue, we can describe the mucosa of the nerve supply to the mucosa of the tongue. Because the anterior two-thirds of the tongue, which is the body of the tongue, derived from the first pharyngeal arch. And the nerve of the first pharyngeal arch is the trigeminal nerve, as we said before a while. So the anterior two-thirds of the tongue is supplied by the trigeminal nerve, which is the fifth cranial nerve, mainly from mandibular branch of trigeminal nerve. While the posterior one-third of the tongue, which is derived from the second, third, and fourth pharyngeal arches, but the third dominates the second and fourth in formation of the posterior one-third of the tongue, which is root of the tongue. Therefore, the mucosa of the posterior one-third of the tongue is supplied by the nerve of the third arch, which is the non-cranial nerve, the glossopharyngeal nerve. And behind the root of the tongue, the part of the tongue derived from the epiglottic swelling is supplied by the superior laryngeal branch of vagus nerve, which is the 10th cranial nerve, because this posterior end of the tongue derived from the epiglottic swelling is derived from the fourth pharyngeal arch. Of course, we are describing here nerve supply to the mucosa of the tongue, because all muscle of the tongue are supplied, or most of muscles of the tongue, not all, most of the tongue muscles are supplied by the 12th cranial nerve, which is the hypoglossal nerve, because most of the muscles of the tongue are derived from the occipital somites, not from the pharyngeal arches. This is all about muscles, the embryology of the tongue. Now we will talk about embryology of the thyroid gland. As we said before a while, the anterior two-thirds of the tongue is called body, the posterior one-third is called the root. And in between the body and the root, there is a V-shaped sulcus called sulcus terminalis. The apex of this V-shaped sulcus is called foramen cecum. Here, the mucosa at the foramen cecum, the apex of the V-shaped sulcus terminalis, the mucosa at the foramen cecum proliferate. It shows epithelial proliferation. And this epithelial proliferation descends downward in a form of what's called thyroglossal duct. This thyroglossal duct descends down in front of the hyoid, in front of the larynx and pharynx, to reach the final position of thyroid gland and form the thyroid gland. This formation occurs during the 5th week, but the thyroid gland development, when it reaches its final position, it will be in the 7th week. The thyroid gland will start functioning in the 3rd month of pregnancy. Sometimes this pathway of the thyroglossal duct from the foramen cecum to the final position of thyroid in front of the trachea, the thyroglossal pathway must degenerate later on, but if it shows a remnants of thyroglossal duct, this remnant may form, for example, fibrous tissue that is above the thyroid gland, above the middle isthmus of thyroid gland. This thyroid tissue in anatomy is called levator of thyroid gland, or levator glandulae thyroidea, fibrous tissue remnant of thyroglossal duct. However, sometimes remnants of thyroglossal duct form thyroid tissue in that pathway from the foramen cecum to the thyroid gland. For example, you may find aberrant thyroid tissue on the tongue, or here, thyroid tissue in front of the hyoid or the larynx. You may even find a pyramidal lobe above the middle isthmus of thyroid gland. This pyramidal lobe is formed by remnant of the thyroglossal duct. Sometimes the thyroglossal duct form a cyst in the midline, which is called thyroglossal cyst, that if it is open to outside, it will form thyroglossal fistula. Of course, this is not a lateral cervical sinus because the lateral cervical sinus is laterally. This is in the midline. You know, the lateral cervical sinus is remnant of the cervical, lateral cervical cyst is a remnant of the cervical sinus, which is formed by closure of the second, third, and fourth arches. This is the lateral cervical cyst is lateral. This is anterior paraglossal cyst. The lateral cervical cyst is at the anterior border of sternomastoid muscle laterally. Now, also in relation to the pharyngeal arches, we will talk about the face, development of the face. Actually, the center of the face is formed by the oral stomatal cavity, and there will be 5 swellings of the face formed around the oral cavity, the center of the oral stomatal cavity. All these 5 swellings are derived from the first pharyngeal arch. The 5 swellings are the following. You have maxillary swellings on the sides of the oral stomatal cavity, right and left maxillary swelling. And you have mandibular swellings caudal to the oral stomatal cavity. The maxillary are lateral, the mandibular swellings are caudal, and both of them are bilateral, 2. While you have 1 swellings, which is called the frontonasal swellings, is anterior or cephalic to the oral stomatal cavity. The oral stomatal cavity is at the center of the face. These swellings are derived from the first pharyngeal arch during the 4th week of development. Later on, the single frontonasal prominence or swelling, which is anterior or cephalic to the oral stomatal cavity, shows bilateral thickening of the ectoderm on the side of the midline that are called olfactory placodes or nasal placodes. And on the sides of this olfactory placodes, the thickening on the sides of the frontonasal prominence, there will be formation of nasal processes, medial and lateral nasal processes. And then the placode, the ectodermal thickening of the olfactory placode, will show a pit which is called olfactory pit. This is the olfactory pit surrounded by medial nasal swelling and nasal process and lateral nasal process. The olfactory pit formed in the olfactory placode will be deepened to form the nasal cavity. Actually, later on, what's going on? That the right and left medial nasal processes unite in the midline, as you can see here. And as a result of union of the right and left medial nasal prominences or processes, they will form a piece which is called intermaxillary segment. This intermaxillary segment will form the middle of the upper lip, which is called philtrum, and also it will form the anterior part of the hard palate carrying the incisor teeth, which is called the primary hard palate. So when you look to the upper lip, you will find the middle of the upper lip is derived from the intermaxillary segment. This middle of the upper lip is called philtrum, is derived from the intermaxillary segment. And this intermaxillary segment is derived from fusion of the right and left medial nasal prominences. The lateral parts of the upper lip, not the middle part, the lateral part of the upper lip is derived from the maxillary prominences. And the lower lip is derived from the mandibular prominences. The nasal pits, as we said, will be deepened to form nasal cavities. And the nasal cavities formed will branch, forming the paranasal air sinuses. Therefore, the paranasal sinuses are branching of the nasal cavity, which is formed by deepening of the nasal pits. You can see also that the groove between the lateral nasal prominence and the maxillary prominence, this groove, form the nasolacrimal, or is called the nasolacrimal groove. This nasolacrimal groove will produce the nasolacrimal duct and lacrimal sac that transmit tear from the eye to the nose. So the groove between the lateral nasal process and the maxillary process is called nasolacrimal groove. Later on it will form nasolacrimal duct and lacrimal sac that transmit the tears from the eye to the nose. The external nose, as it is shown in this figure, is derived from the frontonasal prominence and from the lateral nasal prominence or processes and the medial nasal prominences. So 5 prominences forming the external nose, which is part of the nose protruding from the face. Right and left medial nasal processes, right and left lateral nasal processes, and the frontonasal processes. The paranasal sinuses that are branches from the nasal cavity, which is formed by deepening of the nasal pit. The paranasal sinuses develop during fetal life, but they maturate in adulthood, and thus the shape of the face in adulthood differ from that of childhood because of maturation of the sinuses in adulthood. The cheeks are derived from the maxillary prominences, and also the maxilla bone is derived from the maxillary prominences. Regarding the hard palate, we said that the medial nasal processes fuse to form the intermaxillary segment, and this intermaxillary segments form the middle of the upper lip, which is the philtrum, and the anterior part of the hard palate, which is called the primary hard palate, carrying the incisor teeth. The posterior part of the hard palate, which is the larger part of the hard palate, is formed by shelves from the maxillary prominences, which are called palatine shelves. And you can see that there is an incisive foramen at the junction of the primary palate and secondary palate to demarcate them. The primary palate is from the intermaxillary segment, which is formed by fusion of the medial and of the right and left medial nasal swellings, and the intermaxillary segment from the philtrum of the upper lip and the interior small part of the palate, which is called the primary palate, carrying the incisor teeth. These facial swellings that we have just described, the frontonasal swelling, the maxillary swelling, the medial and lateral nasal processes, if there will be failure of fusion of these facial swellings, the lateral nasal, medial nasal, maxillary, this failure of fusion will result in what's called facial clefts, or called the cleft lip or cleft palate. You will find various forms of clefts in the lip or in the palate and in the face, and they are called facial clefts, resulting from failure of fusion of the facial swellings and facial prominences and facial processes. And this is a big topic, of course. This is all about the development of the face. Again, because we are describing the branchial arches or the pharyngeal arches and pouches, within this subject we have to discuss the embryology of the ear. Anatomically, the ear is divided into 3 parts. The auricle and the ear canal, which is the external auditory meatus, represent the outer ear. The ear canal ends with the eardrum. After the eardrum, we have the middle ear that contains the bones of the ossicles. And next to the middle ear, this is the inner ear, which is formed by the cochlea and 3 semicircular canals. The external ear is derived, as we said, the external auditory meatus is derived from the first pharyngeal cleft, the ectoderm of the first pharyngeal cleft. And therefore, the external ear develops on the side of the neck, but it ascends later on in development. We said that the first pharyngeal cleft is formed of an ectoderm, from the ear canal or the external auditory meatus, and also this first pharyngeal cleft forms the outer layer of the eardrum. The eardrum is formed from inside by the endoderm of the first pouch and by the ectoderm of the first cleft, and between them is a small piece of mesoderm. The auricle is formed by mesenchymal proliferation around the first pharyngeal cleft. There are many mesenchymal proliferation around the first pharyngeal cleft. These mesenchymal proliferations are called auricular hillocks that form cartilage of the auricle. Actually, there are 6 auricular hillocks, mesenchymal proliferation, that will form 6 pieces of cartilage. These 6 pieces will fuse together, resulting in formation of the auricle. This is about embryology of the external ear. Regarding the middle ear, we said that the auditory tube and the tympanic cavity are derived from the endoderm of the first pharyngeal pouch and even the inner layer of the eardrum. So the middle ear is derived from the first pharyngeal pouch. Bones inside the middle ear, which are the ossicles, are derived from the first arch and second arch. The first arch from the malleus and incus, while the second arch from the stapes. And we had just described the tensor tympani muscles of the middle ear, which is derived from the first arch mesoderm. So the middle ear is from the first pouch endoderm, but the ossicles are from the first and second arch, malleus and incus from the first arch mesoderm, the stapes from the second arch mesoderm, tensor tympani is from the first arch mesoderm. Now we must pass to the inner ear. You know the inner ear is formed of 3 semicircular canal and the cochlea. The cochlea carry the organ of Corti and is responsible for hearing, while the 3 semicircular canals are responsible for balance. Of course, this organization is found inside the skull and is called bony labyrinth. Inside this is the membranous tissue of the same shape, which is called membranous labyrinth, and both the bony and membranous labyrinth referring to the inner ear. Embryology of the inner ear is formed as following. First, there will be thickening of the surface ectoderm on the side of the rhombencephalon in the head region. This thickening of the ectoderm is called otic placoid. It will invaginate to form the otic pit and then the otic vesicle, or called otocyst. This otocyst, or auditory vesicles, or otic vesicles, or otic cyst, will form the membranous labyrinth, and the mesenchyme around it will form the bony labyrinth. And that's all. And now, although the embryology of the eye is not related to the pharyngeal arches, pouches, or cleft, but because the eye is part of the head region, we may pass to embryology of the eyeball. As a revision to the anatomy of the eyeball is formed of a posterior 4/5, which is formed of the wide sclera, middle choroid, and the inner retina, while the anterior 1/5, which shows the transparent cornea. The retina is the sensitive part of the eyeball, containing nerve cells that their processes form the optic nerve, which is attached to the eyeball from behind. The anterior part of the eyeball shows the ciliary processes that are attached by ciliary ligament to the lens of the eye, and therefore the lens of the eye with ciliary ligament and ciliary processes divide the eyeball into the posterior segment behind the lens, and anterior segment in front of the lens. And the colored iris divide the anterior segment into anterior chamber and posterior chamber. The anterior chamber between the cornea and the iris, while the posterior chamber is between the iris and the lens. So we have to discuss the embryology of these parts of the eyeball. Actually, the eyeball initially is formed on the 4th week by outpocketing, bilateral outpocketing from the diencephalon. This outpocketing is called optic vesicle. It elongates laterally. This is the optic vesicles that elongate laterally to reach the surface ectoderm on the side of the head. And it will induce this surface ectoderm to be thickened, forming the lens placode. Later on, both the optic vesicle that grow from the diencephalon will invaginate and the lens placodes will invaginate. The lens placode will invaginate from the lens pit and the lens vesicle, while the optic vesicle will invaginate forming the optic cup. As you can see that the mouth of the optic cup will form the pupil of the eye, and the cup will form the following. The anterior part of the cup will form the iris and ciliary body, but the posterior part of the cup will form the retina. Actually, the retina in histology is formed of 10 layers. 9 of these layers are derived from the anterior wall of the optic cup, and the 10th layer only is derived from the posterior layer of optic cup. And you can see that there is a space between the anterior layer of the optic cup and posterior layer of optic cup, which is called intra-retinal space. After development, the anterior layer of the optic cup will form 9 layers of the retina, while the posterior layer will form only the 10th layer, which is called pigmented layer. And this intra-retinal space will be closed by fusion of these 9 layers derived from the anterior wall with the 10th layer. But in diabetes and hypertension, this intra-retinal space will detach in a condition which is called detachment of the retina. The intra-retinal space will occur in diabetes and as a complication of diabetes and hypertension. So the separation or detachment of the retina is between the 10th layer, which is derived from the posterior wall of the optic cup, from the 9 layers of the retina derived from the anterior layer of optic cup. These 9 layers are called neuronal retina, while that is called pigmental part of the retina, or non-neuronal. The non-neuronal retina is a 1 layer derived from the posterior layer of optic cup, while the 9 layers of the retina, which are neuronal, derived from the anterior wall of the optic cup. As we said, the retina occupies the posterior 4/5 of the eyeball. The anterior 1/5 of the eyeball, including the ciliary body and the iris, are derived from the anterior part of the optic cup. Only the anterior 1/5 of the optic cup will form the iris and the ciliary body. You can see that the mouth of the optic cup contains the lens vesicles, and the lens vesicles will form the lens of the eye. Of course, going back to this figure, this is the lens and this is the optic cup. The ectoderm covering the lens of the eye will form the cornea. This is the ectoderm, surface ectoderm, that will form the transparent cornea. And also the extension of the optic cup from the diencephalon is called optic stalk, that will form the optic nerve. You can see that the eyeball is connected posterior to the optic nerve. And if you go to the embryological origin, you can imagine that when the optic vesicle elongate, the connection of the optic cup with the diencephalon is called optic stalk, which is this one, connecting the optic cup with the diencephalon. This optic stalk will be later on forming the optic nerve. The sphincter and dilator pupillae muscles are derived from the ectoderm over the optic cup. And the anterior 1/5 of the optic cup will form the iris and ciliary body. Ciliary muscles are derived from mesenchyme of the ciliary body. The optic stalk will show a ventral groove which is called choroid fissure. This is a transient groove that should disappear, but if this groove will not disappear, the choroid fissure on the ventral aspect of the optic stalk, it will produce a condition which is called coloboma, in which part of the colored iris is absent, as you can see. If this defect in the iris extends posteriorly to the retina, there will be a coloboma iritis with impairment of vision. But if it is only involving the failure of closure of the choroid fissure, if it's only involving the iris, so it is only coloboma iritis, and there will be no impairment of vision. But if it extends posteriorly, it will reach the retina and impair vision. That's all about embryology of the head, ear, and eye. Thank you very much.